Hello everyone, my name is Raj Patel and today I'm going to present a case for Mr. Richard who is 54-year-old male, was in the clinic today with his chief complaint for depression and has a desire to take control of his life again. History of present illness. RT is presenting to the clinic today with a sign of severe depression. According to the patient, he has suffered from a terrible depression since his last heart attack in 2015 and has exhibited a depressed mood consistently for a period of past 6 months. He reports of losing interest in his hobbies like building model train in his basement and has a constant feeling of guilt, fatigue, and worthlessness. He feels less inclined to spend time with his friend and has had trouble recently with his ability to concentrate at work. Patients state that this season is particularly difficult for his depression with colder weather, holiday, and spending his birthday alone contributing to his overall feeling of worthlessness. RT doesn't exhibit suicidal ideation or any symptoms of bipolar disorder, mania, anxiety, or insomnia. According to the patient, treatment with citalopram was initiated 2 years ago. It worked very well in improving the symptoms, but it caused erectile dysfunction, diarrhea, which resulted in the discontinuation of the therapy. Today, he is motivated and would like to restart the therapy with something that doesn't cause him any side effect. He claims that if he can control his depression, he would be interested in quit smoking, and if he can breathe a little bit better, he will start to exercise. He doesn't exhibit severe breathlessness at rest, but does complain of mild shortness of breath and trouble breathing while exercising. He doesn't exhibit any sign of bronchitis, but he claims to be compliant with his all medication. His medication list include metoprolol ER 50 mg by mouth once a daily, fluticasone 100 microgram 1 inhalation BID, albuterol 2 puffs every 4 hours as needed for shortness of breath, aspirin 325 milligram by mouth every day, and he got his pneumonia vaccine in March of 2017, and at the same time he received his flu shot as well. His priority problem list include depression of highest priority, COPD is the next level of his priority problem, followed by myocardial infarction, dyslipidemia, and obesity. Family history, patient has family history of cardiovascular disease and depression. Social history, patient smokes a pack of cigarette a day, drinks alcohol occasionally, but had recently drank more during holiday season, and his wife passed away last year. Upon physical examination, patient has sign of moderate depression, which is evidenced by his history of present illness and HMD score of 16, and has moderate severity of COPD, which can be confirmed by post-bronchodilator FEV1 percentage of 52. And he doesn't exhibit any sign of bronchitis at this time. Upon physical examination, RT found to be overweight and in depressed mood overall, with elevated BP of 138/86 and 129/88 when repeated. Other vital signs are within normal limit. Assessment of disease. Patient has moderate severity of depression, which is evidenced by his HMD score of 16. Patient experiencing depression since 2015 and consistently in depressed mood for a period of last 6 months. However, doesn't have any suicidal ideation, bipolar disease, mania, anxiety, or insomnia. Patient has family history of depression and cardiovascular disease, which is the most contributory cause to the disease. Cold weather, holiday, and spending are least contributing towards the disease. Patient meets all the criteria for DSM-V for depression since patient is experiencing depressed mood for a period of 6 months and has lost his interest in his hobbies and feeling of fatigue, difficulty to concentrate, worthlessness, guilt, and impaired social interaction with his friend, which clearly indicates the patient has major depressive episode. The next priority problem is moderate severity of COPD, which can be confirmed by CAT score of 21. He is not experiencing any shortness of breath while on rest, but experiencing mild breathlessness and trouble in breathing while exercising, and doesn't have any sign of bronchitis. Patient's smoking habit is contributing towards the worsening of this disease. As per the GOLD guideline classification of COPD, patient has moderate in severity of COPD based on his severity of airflow limitation or post-bronchodilator FEV1 percentage predicted is 52, which falls in a range of 52 to 79. Assessment of current therapy. Patient has tried citalopram 20 mg once a day, which was working well for the patient and in controlling the symptoms, but patient has adverse event like diarrhea and erectile dysfunction, which resulted in the discontinuation of the therapy. So this medication seems to be inappropriate for the patient. For COPD, patient is taking albuterol 2 puffs by mouth every 4 hours as needed for shortness of breath, and fluticasone 100 microgram BID. Albuterol is as appropriate for the patient as this is a short-acting beta-2 agonist for the patient. Since this medication is indicated for treatment and prevention of bronchospasm in a patient with reversible obstructive airway disease. It can be also used for the patient in the prevention of exercise-induced bronchospasm as the patient is motivated for the to exercise. So this medication seems to be appropriate for the patient. Fluticasone is inhaled corticosteroid, which is inappropriate for the patient due to the adverse effect. According to GOLD guideline, combination of LAMA and LABA, which is long-acting muscarinic receptor antagonist and long-acting beta-2 adrenergic receptor agonist, is appropriate combination. Since this combination has shown superiority in reduction of the symptoms than any other monotherapy and has a greater improvement in FEV1 with the strongest level of evidence. So my goal of therapy would be remission and restoration of baseline function, reduce long-term lung function decline, prevent and treat exacerbation, reduce hospitalization, morbidity, and mortality, improve exercise tolerance and health-related quality of life, and motivate patients for smoking cessation. Plan and recommendation. I would recommend to start bupropion 150 mg SR once a daily by mouth in the morning for 3 days. May increase to 150 mg twice a daily with maximum dose of 400 mg per day, given 200 mg twice a daily. Separate all the doses by 8 hours at least. Maximum single dose is 200 mg, not to exceed 200 mg at one time. Bupropion is a typical my reasoning for the therapy is that bupropion is an antidepressant having less incidence of diarrhea and sexual dysfunction than SSRIs, which patient has experienced in the past. The dose of bupropion will be also indicative and assist the patient for smoking cessation. For COPD, I would recommend to continue albuterol HFA 2 puffs by mouth every 4 hours as needed for shortness of breath and as a rescue, and it can be also used as a rescue inhaler for the patient. I would also recommend to discontinue fluticasone 100 microgram and start Anoro Ellipta 1 inhalation and not to exceed 1 inhalation in 24 hours as that's a maximum dose. See, I choose this medication because it's a combination of LAMA and LABA, and this combination has shown superiority than any other monotherapy or combination as per GOLD guideline. Non-pharmacological recommendation for the patient. I would recommend patient to avoid alcohol while on bupropion therapy And to prevent exercise-induced bronchospasm, use 2 inhalation 15 to 30 minutes before exercise. The effect of this medication may last for 4 to 6 hours with proper inhalation technique, and rinse the mouth with water after each dose. I would highly recommend patients to go for weight loss program, for pulmonary rehabilitation program for 6 to 8 weeks, and cognitive behavior therapy for the depression. I would also recommend to stay up to date with his vaccination and get current flu shot for this year. And follow up in 4 weeks for reevaluation of the therapy, and call pharmacy if patient has any question on or concern regarding any of your medication. And call 911 in case of emergency. Monitoring and efficacy of the therapy. For bupropion, improvement in the signs and symptoms of the disorder, including improvement in sleep, appetite, interest in work and recreation, restoration of mood and congruent effect, personal grooming, and ability to conduct activities of daily living is indicative of efficacy. Abstinence from tobacco product is indicative of its efficacy too. Monitor patient closely for worsening of the depression, suicidal tendency, or unusual change in behavior, particular during the initial few months of the therapy or at the time of dose change, either increase or decrease. Monitor blood pressure as a baseline and periodically during the treatment. Monitor renal function routinely. Monitor INR periodically, since concurrent use of bupropion and aspirin has a moderate risk of bleeding. Screen the patient with depressive symptoms for bipolar disorder and mania or hypomania. For anorolipta, improvement or maintenance of respiratory functions in the patient with COPD may indicate efficacy. Reevaluate respiratory function in patient with a sign or symptoms suggestive of deterioration of disease. That's all. Thank you for listening me. Thank you.